was one of the investigators on the certain phase 3 clinical trial, and I think the experience is similar to what has been presented in terms of how the patients currently behave in terms of their ability to tolerate the drug. I don't think there are any specific differences in terms of the side effects from, in my experience based on between the oral and the IV. Definitely the ability to need less frequent visits, I think, is an attractive appeal for the use of oral agents. So I think my experience has been really in line of what has been presented in the abstract in the American Society of Hematology meeting.
As a clinical center, the Fred Hutch did participate in the Ascertain trial, the phase 3 randomized study. We enrolled several patients into the clinical trial, and we were, pleased with the compliance. Patients tended to tolerate the oral medication well without significant side effects. I think it's important to keep in mind that as physicians, we put our own observations into the appropriate context of a larger clinical trial and the results of the larger clinical trial. So the plural of anecdotal information is not data, as has often been said. So I have anecdotal information about the Ascertain trial based on my own clinical experience, which is useful. But I think it's important that we always be careful about how we take our own anecdotal experiences and say what necessarily other people should do or what other people should get from conclusions of a study. And I really believe that it's important that we look at the broader population as a whole. So I want to be cautious in how people view or interpret my own clinical experience.
I think if the drug is approved, I think it's probably going to be, it's definitely going to be, I think, have a major impact. In MDS, we did not have any drugs approved since 2006, decitabine, which is, kind of interesting that the last drug approved for high-risk MDS was IV decitabine in 2006. And since then, we only had luspatercept just approved 2 weeks ago, but this was approved for lower-risk MDS. So if this drug, the oral decitabine, gets approved, it would be the first drug for high-risk MDS approved in 14 years. And I think probably it's going to affect or it's going to change how patients are treated in the frontline setting, which is somewhat similar to how the study was done. So patients will be getting it from the get-go. It would be interesting to see how do people choose between the oral version versus IV decitabine or IV/sub-Q azacitidine. As I mentioned, I think there could be other factors that play in, such as logistical reasons, how far they are from the center, what's their experience with IV injections, what's their cost-sharing component. All of those factors, I think, are going to play in. But I think the availability of oral agents, not only, I think, in terms of making things easier for patients, but they could be also a backbone for combination-based strategies. A lot of the clinical trial efforts in MDS are currently focused on combining hypomethylating agents with other agents. So having the availability of oral agents could open the door for clinical trials with oral hypomethylating agents, plus minus basically other agents, and you could have total oral therapy. We have another hypomethylating agent, oral azacitidine, that also had a positive phase 3 trial in the maintenance setting for after chemotherapy induction or consolidation chemotherapy for older patients with AML. So I think the availability of those oral versions could significantly affect how we treat patients with MDS and AML, and if those drugs are approved, and this could be a major change in my view.
If the oral cedazuridine decitabine trial leads to approval of that oral medication, I would expect wide uptake of the medication in community practices. I still would try to persuade patients and physicians to support clinical trial development, because I do think it's appropriate to say that we need to try to improve results seen with hypomethylating therapy alone. One of the interesting aspects about the approval of oral hypomethylating therapy is how we take that into the context of the use of oral venetoclax, and whether people will start combining oral venetoclax with oral hypomethylating therapy, and whether we know that that's going to lead to superior outcome of oral hypomethylating therapy alone. One would prefer to have those questions answered in a clinical trial rather than just people doing what they would want to do, because the oral combination therapy with hypomethylating agents and venetoclax could lead to worse outcomes, worse side effects. There could be issues with absorption. So I think it's important that we keep that in mind.